We are now on to our next keynote speaker. It's my pleasure to introduce Dr. Linda Bell. Dr. Linda Bell trained in internal medicine at the University of Texas, Southwestern Medical School, and she has worked in public health for over 28 years. She has served as an epidemic intelligence service officer with the Centers for Disease Control and Prevention, Viral Special Pathogens Branch, and as an EIS field officer. Dr. Bell has served in several positions with the South Carolina Department of Health and Environmental Control, where she's currently the South Carolina State Epidemiologist and the Director of the Bureau of Communicable Disease Prevention and Control. Her responsibilities here include oversight for the agency's programs for acute disease epidemiology, immunizations, STD and HIV, and tuberculosis control. In her work, Dr. Bell has endeavored to draw attention to addressing social determinants of health and public health interventions to help reduce health disparities. Throughout the ongoing COVID-19 pandemic, Dr. Bell has been a lead medical advisor in South Carolina, providing science-based guidance to control disease spread. Her role has included long hours and long weekends in service to the state and our population. Dr. Bell is also involved with several community organizations, and she has served on the board of trustees for Adventure Children's Museum, Healthy Learners, Heatwood Hall Episcopal School, and Francis Burns United Methodist Church, where she's a member. Dr. Bell is married to Dr. Myron Bell, a cardiologist, and the proud parents of two young adult children, Olivia and Morris. And it's my great pleasure, and I'm excited to hand it over to Dr. Bell to present to all of us today.
Conference. I see that the organizers have planned an agenda of thought-provoking topics that promote and celebrate innovative uses of big data. But I will primarily focus my presentation on questions about how big data is used and how it could be used to more effectively support an ultimate goal of improving population health. And I will use the COVID-19 pandemic as a case study throughout my presentation. I looked at many new opportunities resulting from linking data sets, analyzing, interpreting, visualizing, and disseminating findings for big data applications. For example, entrepreneurial big data is where the business sector compiles data of customer choices, spending habits, and social media use to personalize targeted marketing to promote products and influence buying behaviors for profit. Healthcare researchers use big data to identify disease signs and risk factors and enhance diagnostics and treatments that often result in financial benefit in the biomedical sector. Using big data to develop successful public health interventions that change outcomes are not as mature as in these other sectors. Public health workers are combining data sources to improve surveillance for health conditions, correlate risk factors, environmental factors, and other contributors to compile more timely data about population-based health factors. Mining demographic, geographic, socioeconomic, and risk factor data can help predict outcomes like life expectancy, educational attainment, even the likelihood of incarceration based on where you live. This means big data brings the opportunity to improve societal health and realize economic benefits. I see reasons why the opportunities to use big data to improve outcomes for populations at risk may not be happening to the extent that it could. Here's one reason. I found this image and many others by Googling big data and public health. This graphic from the University of Michigan School of Public Health's website shows imagery of patient charts, pills, diagnostic testing, etc. But the image is intended to reflect how public health uses big data. The majority of the images I found from my search also link to resources about big data in the context of health records and interactions with healthcare for diagnoses, treatments, and outcomes for individuals. So one reason that I question if big data is used to improve population health to the extent that it could, is this fundamental misunderstanding that healthcare and public health are not the same thing. I will show shortly how healthcare plays an important but small part in improving public health. If we incorrectly define what we're looking at, we're unlikely to get the results we want. Public health improvements and those studies should focus on data defining populations, demographics, socioeconomic status, environmental exposures and experiences, the social determinants of health. Big data researchers should venture to design projects with the goal of translating findings into the development of public policies that address improvements in social determinants of health. Given the successes of big data in medical advances, social media, marketing, artificial intelligence, and other fields, we need similar successes with big data to improve public health. As I talk about public health data, it's important for me to discuss some shortcomings that exist and the need for data modernization in public health departments. We have several collaborative agreements with big data researchers at the USC School of Public Health and the USC School of Medicine and others related to associations between COVID and various diseases and other circumstances. So I want to discuss the pre-pandemic infrastructure in public health departments nationwide and expectations imposed on us to provide data about COVID while cases were rapidly increasing from the pandemic. There were lots of misperceptions about data that people believed was readily available. The response to the novelty, size, scope, and speed of the pandemic was very different from routine public health surveillance and data collection activities, and this had huge implications for our ability to support all data requests during a pandemic. Big data, in general, was initially characterized by the 3 V's for data: volume, variety, and velocity, meaning harnessing a large volume of data in many environments from a wide variety of data types frequently stored in big data systems, and the velocity at which much of the data is generated, collected, and processed. So I'll use the case study of the data needs for COVID pandemic response. Public health authorities were expected to manage unprecedented volumes of data, to acquire a variety of data types, including from non-traditional reporters who were unable to submit automated reports, and to produce cleaned, validated data on a velocity of a 24-hour reporting cycle from the beginning of the pandemic. These may be somewhat invalid comparisons with big data terminology, but it is a valid point that the pre-pandemic public health infrastructure was insufficient to address the expectations for COVID-19 data. Many healthcare systems and providers were unprepared to report rapidly because they lacked the capability of automated reporting from electronic health records and labs. Some were phasing in electronic laboratory reporting, but public health staff nationwide still receive fax, phone, and mailed case reports that must be manually entered. Chronic underfunding for public health infrastructure meant that during an evolving pandemic, we essentially had to grow a workforce of data managers, statisticians, epidemiologists, informaticians, IT specialists, and others to modify our disease databases that were not designed as lab reporting systems. And we lacked interoperable systems between disease, immunization, and vital record statistics registries and laboratory systems. All of these were essential to meeting the needs of monitoring the impact of the disease on the population and for us to respond rapidly. Beginning in 2020, the federal government provided Coronavirus Aid, Relief, and Economic Security Act, or CARES funding, to accelerate public health implementation of data modernization efforts for infrastructure, electronic case reporting, vital statistics, and other symptoms, to move towards faster, more automated data sharing for real-time exchange of more complete case report information between electronic health records and public health agencies. With new resources, we are now beginning to build this infrastructure, but this will likely take years. I will say that part of the Data Modernization Initiative involves a baseline assessment of our infrastructure and our needs. And we're doing this now. And one principle that they are asking in data modernization is to focus on applying good ethical practice and value judgments related to data collection, dissemination, and use. This principle should be applied in all public health big data initiatives. And with these principles in mind, I will discuss how it should be applied. I'll move to examples of the use of existing data with regards to health disparities. Are there existing data that compel us to make value judgments about how data is used and how it could be used? This graph shows growing national health expenditures as a percentage of the gross domestic product from 1987 to 2011 in the United States. In the book Health Disparities in the United States, Social Class, Race, Ethnicity, and Health, Donald Barr shows that the United States spends far more of our national economy on health care than any other developed country in the world. Can big data make comparisons with other developed countries to help us make policy decisions about how to better invest healthcare resources to improve health outcomes? The Kaiser Family Foundation Health Systems Tracker shows in this graph health consumption expenditures per capita in US dollars. Because health spending is closely associated with a country's wealth, this chart compares the United States to similar countries in the Organization for Economic Cooperation and Development, or OECD, an association of the most developed countries in the world, those with above median incomes as measured by GDP and median GDP per capita. Health spending per person in the United States, shown in the green bar at the top, was $11,946 in 2020, which was over $4,000 more expensive than any other high-income nation. The average amount spent on health per person in comparable countries is roughly half that of the US. The Health Systems Tracker notes that making direct comparisons of health spending among countries is complicated due to differing political, economic, and social attributes that contribute to spending. Perhaps these various attributes could be studied further to change policy decisions in the United States for the following reasons. Despite US expenditures, our population has poorer health status than populations in other OECD countries. This graph shows that for both men and women in the United States, we rank lowest in life expectancy at birth among OECD countries. Additionally, the US has the highest infant mortality rate, higher than 30 of 34 countries in the OECD, and from another source, the US ranked 12th in the world for obesity, higher than any other developed country. How can big data examine how the US differs from similarly developed countries? Considering the countries compared here raised some questions for me. What is the racial diversity like in other countries like Switzerland, Sweden, Japan, the Netherlands, Belgium? With some exceptions, my guess is that the US has more quote-unquote racial diversity. But race is really a social construct. All humans have very similar genetic makeup, so race doesn't truly exist at the genetic level. So one of my questions is, does the way that observed racial differences are treated in the United States exist in other countries? Is race itself a factor in health disparities, or is how we treat the social construct of race the difference? Can big data tell us what role diversity in race, or the lack of it, plays in systemic disparities? What about cultural behaviors? For example, do other countries have similar prevalence of fast food options contributing to obesity? What can big data tell us about cultural differences, societal influences, public policies, and priorities for spending that influence health? And very importantly, what data sources are missing to help answer these questions and influence change. Our country is rich in resources, but low socioeconomic status is pervasive. We have existing data defining these problems. Can big data examine how we prioritize our resources to change this? We should use big data to tell the story in this country and influence policy changes and ultimately improve outcomes at the population level. So many discussions about improving health in the United States focus on improving access to quality health care. While this is an important contributor to reducing disparities in chronic conditions, disparities in health status have more to do with social determinants of health. Addressing the social determinants of health is needed to improve population health status. The five-tiered health impact pyramid describes the impact of different types of public health interventions and provides a framework to improve health. Interventions moving from the top of this pyramid to the bottom move to more impactful population benefit. Health education and counseling at the top of the pyramid are very common public health activities, but if used alone are the least impactful. They are generally based on beliefs that if you educate people, they will do what's good for them. But like so many of us who know we should exercise regularly or not eat or drink what we are eating and drinking, we know that education alone doesn't translate to behavior change without supporting environmental changes. Looking next at clinical interventions, where the United States spends the greatest amount, requires ongoing direct clinical care. We have electronic health records to improve access to data and the coordination of medical care, but clinical interventions are more costly and primarily benefit only those individuals who have access to them, not the population as a whole. In the middle of the pyramid are long-lasting protective measures like immunizations. These do require individual decisions and clinical interventions with limited contact, but they confer long-term protection and are therefore more effective. All the tiers have benefits to varying degrees, and implementing interventions at each of the levels can achieve the maximum possible sustained public health benefit. But it is environmental changes that benefit people without them having to take some deliberate action, like clean air, fluoridated water, foods without trans fats, sidewalks, and laws and policy decisions and infrastructure investments are more successful interventions. But at the base are interventions that address socioeconomic factors like poverty, education, housing, and income inequality. These are the strongest determinants of health, and these persistent social problems are in the purview of public health, and we should be using data to examine the impact of earnings, of adequate housing, and publicly funded early childhood education, for example, to have the greatest impact on healthy people living in healthy communities. How can big data influence needed policy changes? To dedicate resources to socioeconomic factors. What data can be provided to show long-term versus immediate economic benefit to societies? And can big data for health identify strategies for behavior change, as is done with entrepreneurial big data? What complementary programs are needed for educational campaigns designed with certain outcomes in mind to be successful? And finally, how can big data help evaluate the effect of interventions designed to address socioeconomic factors? Because unlike clinical interventions with more immediate impacts, effectiveness evaluation is hard to capture because change takes so long. That's why studying other countries and other societies where health status is better is important. Early in the pandemic, CDC published an article in the Morbidity and Mortality Weekly Report that stated that long-standing systemic health and social inequalities have some members of racial and ethnic minority groups at increased risk of getting COVID-19 or experiencing severe illness. Now, I have shared this map created by Dr. Avarabatu of Keene University many times. It was created relatively early in the COVID-19 pandemic, but it was during a time of high and widespread COVID-19 activity. This is a GIS map of social vulnerability index within zip code boundaries, overlaid with COVID-19 case rates in pink circles and mortality rates in red circles. Areas of high SVI are shown in red, and orange zip code boundaries indicated by higher poverty rates, lack of access to transportation, and inadequate housing, and other factors that increase a community's vulnerability to disasters. So I'm sharing this slide not as current COVID-19 data, but for its powerful visual image. Presumably with the emergence of a novel virus to which no one had immunity, we should see uniform susceptibility if all factors are the same. And in fact, the size of the pink circles showing similar case rates across SVI areas suggests similar susceptibilities to exposure. But the dark circles showing higher COVID death rates in zones of high social vulnerability tell a different story. And this map represents pre-pandemic failures that are long-standing in public policy, resulting in populations at higher risk for death, for COVID, but also other detrimental health effects. How does this occur? So here's a tale of one city. If I look at an example from the New Deal, where a housing shortage in 1933 led the federal government to design a program to increase America's housing. The efforts were primarily designed to provide housing to white, middle class, and lower middle class families, but people of color were excluded from the suburban communities and pushed instead to urban housing projects. These images are not really from the same city, but you can find these differences in any medium-sized city in America today. And how we see this today is called redlining, which is still a pervasive discriminatory practice in which services, financial services and otherwise, are withheld from potential customers who reside in neighborhoods that are classified as hazardous to investment. These residents are largely racial and ethnic minorities. And so today, the social circumstances that our federal government policies created, like the New Deal, are used as the basis of denying services, financial benefits like home loans that would allow people to live in affordable housing in areas where there are well-resourced schools, good grocery stores, and public recreational facilities. And this makes a huge difference in health and other disparities. So we should consider that just one of the consequences of the pandemic is supply shortages that are contributing to another housing shortage now. What data do we need to prevent a recurrence of the New Deal policies? Reducing social vulnerability can decrease human suffering, but also social disruption and economic loss and result in long-term societal benefits that we really should be looking at. An article published in the American Journal of Public Health, Future Directions in Residential Segregation and Health Research, a multi-level approach gives suggested strategies for big data to address, developing multi-level research designs to examine the effects of individual, neighborhood, and metropolitan area factors on health outcomes, and developing better conceptual frameworks of this pathway that may link segregation to specific health outcomes. We need more big data projects like this. So addressing the needs of disproportionately impacted individuals improves their day-to-day life and increases resiliency in some racial and ethnic minority groups. But it's important for everyone to understand that addressing disparities or inequities impacts the quality of life for everyone. It improves the availability of shared resources. It reduces the risk for disease exposure. It reduces health care and other societal costs that we all ultimately pay for. It reduces impact on the essential workforce for services, supplies, food, public safety, education, and so many other factors. Because we are all connected, even those who believe they are untouched by disparities are not. A disadvantage to anyone creates a societal disadvantage that we all pay for. Dr. Richard Besser, who's a former acting CDC director and now president and CEO of the Robert Wood Johnson Foundation, discusses health equity and reimagining our data systems to transform public health. He said that one of the pandemic's many lessons is that we must reimagine how we think about, collect, and then act on public health data, and it must begin by centering equity in these efforts to eliminate racist systems and structures. We have known for years that these disparities persist, yet the United States still does not have complete real-time data to identify and sufficiently tackle such disparities. We need a robust, modern data infrastructure that collects the data we need and connects the dots between public health data and other sectors, housing, education, employment, and others for starters, to create a more equitable future. And as part of the Robert Wood Johnson Foundation's work, a national commission to transform public health data systems was created to reimagine how data are collected, shared, and used. This commission was charged with identifying what public and private innovations are needed to create the data infrastructure that can lead to health equity in the United States. And the commission provided a blueprint for change that endorses the principles that our data systems must provide: indicators of the health harms caused by racism and other forms of discrimination, and the evidence to eliminate these inequities. The Commission's recommendations include improving the collection of self-reported data by race, ethnicity, income, education, gender identity, sexual orientation, disability, and social position in communities to allow for the necessary granularity to address the specific health equity challenges within particular groups. For developing powerful local data collaboratives that link social determinants of health that are now missing. Most governmental public health data sets do not contain this information, but it would help local health departments in partnership with community organizations to prioritize and address local health challenges. Building community academic partnerships with historically Black colleges and universities to expand capacity in the creation, collection, analysis, and interpretation of data, with the goal to transform local public health data systems to address health equity. In closing, we have realized decades of advances in diagnostics, treatments, and clinical technologies. And despite these, overall health status in the United States remains unchanged for many population groups. For big data to improve health factors, we will need a better understanding of contributors to public health, and a greater focus should be given to defining how we are using and how we could be using existing data. But also to refine big data goals to influence health in all policies, to describe expected outcomes, benefits, and cost effectiveness for society to policymakers. We should continue to explore available data sources, but also ask what data are missing and what non-traditional data, like behavioral data, can be used to achieve equality in the social determinants of health, in life expectancy, educational attainment, economic opportunity, and the opportunity for everyone to live in a safe environment. We should engage input from impacted communities. Correcting the generations of harm will take years of engagement to change that, but we should be asking now, what do we need to do? How do we engage these communities? And we need more structured input from impacted communities to help us understand this. And we must maintain community relations to meaningfully share big data findings for local change. Before I stop for questions, I want to acknowledge the collaborative relationships for big data projects and other data sharing agreements with our many partners that benefit public health outcomes. I've listed only a few, but they include academia, healthcare systems, other state agencies and organizations, as well as many public health programs in DHEC. I want to thank everyone for their extraordinary efforts to help improve public health. Thank you.
Thank you, Dr. Bell. We truly appreciate that. We'll now open the floor for questions from our attendees.
For people with questions, you can post them in one of several places. In the chat box on the Zoom video, in the chat box on the side of your Whova screen, or in the Q&A in Whova.
And then when those questions come in, as they come in, we'll be asking. There's one. What would be your suggestion, Dr. Bell, on practical ways to bridge the gaps on the availability of public health data and the linkages that are needed to other individual non-public health data?
So to bridge that gap between I think you're asking about, there's actually existing data, correct?
Correct.
So, much of this stems from, we rely heavily on federal funding that is condition specific. So I think the onus is on us in public health to find how to more integrate the way we look at conditions in terms of how these, as we focus on them as individual conditions within programs, but they impact the populations, the same individuals and populations. So I think the onus is on us to integrate how we're looking at our programs and how they touch populations, but also the way that we're structured in agencies and institutions does not allow as much of a structured and ongoing relationship with communities. And so I think for us to sort of look at how we can redesign the way we work to maintain continued engagement from community groups. We have a few community health panels that we routinely provide our data for and get their input. Oftentimes we will tell communities, these are our concerns and this is what you need to do. And we need to create more avenues to ask communities, what are your needs and what are you thinking, what are your priorities, and match those up. So I hope I've answered that question.
Yes, thank you. We appreciate that. There's another question from the audience. It asks, are there any downsides of using big data to inform policy making?
Well, I think a downside is potentially in the interpretation. So, when people collect and analyze data, we do have a responsibility for interpreting that data, because those who conduct the surveillance and collect the data may often know more about the shortcomings. So for example, what's not collected. So they're not making incorrect inferences about data that may not be representative, or there are lots of, there are lots of issues. So when we explain the data with policymakers, we have to make sure that they understand what it does and does not represent. So that's a potential shortcoming. And then I think separating politics from policymakers, that there is a potential shortcoming there, that if we can focus on the science and remain engaged with policymakers and focus on health and all policies and step away from the politics of it, there's not necessarily shortcomings there, but potential barriers for how we can use data to influence public health policy.
Thank you. There's another question from the audience here that I think is looking into the future, and they want to get your sense of how big data can play a role for population personalized interventions, or more specifically, precision public health.
I just think that's a great question that I do not have the answer to, but I think we should all be impressed in how successful they do this in entrepreneurial big data or in other sectors. And so, one of the points that I wanted to make is that they, and this may have to do with infrastructure investment, because big businesses and the private market have a lot more resources than we do in public health. But they obviously are very successful at changing behavior with purchasing habits. We know that we're all influenced by advertising and marketing. And so, are there ways that we can personalize our big data for public health purposes to the extent that this has been successful in the private sector? And so I appreciate that question, and I just think it bears giving it more thought. As I've mentioned, that I think in public health, we're in our infancy in using big data to change behavior instead of just educate. And I would look forward to those opportunities.
There's a question here from Dr. Zimmerman that asks, do you have any suggestions on how we can test health behavior models with individual level data and things like perceived susceptibility to communicable diseases or attitudes about health behavior linked to the community, neighborhood, or county level public health data? Kind of a mouthful.
Right, and I think capturing behavioral data more systematically is part of that. And that is, for anybody who's tried to do that, it's tougher to conduct, well-designed focus groups and really understand behaviors and other influences. I think if I'm understanding that question correctly, is to get at that. So, we tend to focus on the easier interventions like the health education and whatnot, but the part about behavior is the tougher part that requires more complicated. It's more complicated to collect the data and more complicated to measure the outcomes.
Thank you. We have another question here that is focused on data modernization. And the quote to say, sometimes we're driven by technology instead of science, using technology as a tool. What do you think is the biggest hurdle to data modernization based on what you've talked about?
Well, from, again, the public health perspective, one of the biggest issues is us being sort of so far behind with data modernization initiatives because of underfunding. We really, in many ways, we're dealing with very antiquated systems. They have to talk to each other. We are working with healthcare systems to be able to get information electronically in a more automated way. But this, from where we're starting from, will take quite some time, and so I think it's the saying that we are driven by the technology instead of the science. Is this the question? The biggest hurdle is, I think, the investment, but nonetheless, we do have available data now, and I think strong and continued partnerships with academia to help us use this data and agreements to help us share the data while maintaining, the confidentiality and the security are things that we're continuing to work on. So those are some of the hurdles that I think we're making good progress. Would like to see that advance as rapidly as possible.
Thank you. There's another question here, and it goes back to that data not talking to each other. And wanted to see what your comments are, especially based on your initial figure where you showed why people don't understand public health big data. Can you comment on any opportunities you see for us to integrate social determinants of health data with electronic health record data so that we can better coordinate services between actual care delivery and public health agency work?
So I think we're working on that now, and I think one of the things is just a focus on maybe that it's there, but not all of our partners are paying, including us, and all our programs are paying the attention to it that it deserves. And so that would be one big step forward. And also I make the point of the focus on the technologies and the clinical care. So of course, very important, but access to care is important, and increasing that access to care. And so there are so many elements to work on in that area. I feel like I'm sort of a long question. I'm probably not giving the best answer there, but I just see it as many opportunities to be addressed, and just defining the end that we want to get to from the outset will help us as we design these projects. So some of it is just mining the data because it's there, But I think an important thing to add will be, where do we want to get to before we start? And again, conversations with impacted communities and policymakers. I think that's another area where we really need to develop relationships for policymakers to accept the importance of this data and be in it for the long game, because we are very much focused on immediate benefits. And this investment in where we want to be, because it's going to take years to get there, we have to have an understanding that we have to do this investment now and have some patience, but understand that there are long-term economic benefits for all of us if we just sort of change the way that we are looking at immediate benefits versus long-term benefits for entire populations. Sorry for that wordy response.
No, that is okay. I'm going to consolidate for time a couple of questions here, but it has to do with the actual, what your thoughts are again around facing big challenges in missing data. Again, you mentioned in your talk that we've been underfunded, so your department had to ramp up very quickly and pull all this expertise in. So we have issues of missing data, whether in public health data or in electronic health records data. Sometimes key features of social determinants of health are missing, such as race, and those key social determinants of health factors really complicate our ability to study or understand or motivate policymakers. Because the question is, if it's not there, what can we use? Do you have any suggestions on how we can bridge some of those gaps, or how we can motivate data creators to make sure they accurately include all the variables necessary?
Well, automation will help us a lot in that way. As if we stop relying on providers having to fill out forms and include that information, or even asking for the information in some times is why it's missing. But when the information is captured but it's not transferred automatically, that's one of the issues. And also getting people more comfortable with capturing the data. Sometimes they don't ask, they don't want to ask, they make assumptions. You can't really define race by the way, by looking at somebody. And so capturing it, transmitting it, all of those things, transmitting it in an automated way will help with completeness of data for demographics.
All right. We have 2 minutes, so I'm trying to make sure I cover as many of the questions as possible. Okay, so this is a question directly to you, and just saying, so you talked to us about the challenges with public health funding and all of that, but this person wants to know, so what is the status today right now of the resources that DHEC needs in terms of staff and equipment for DHEC to truly be able to handle big data?
Well, the infusion of federal funds has been a big help to us, and a lot of that came because of the pandemic. And we hope that investment in public health will continue in the future. So that there are some tendencies when a problem begins to resolve but is not completely resolved, then funding streams go in another direction. So the ongoing and continued investment in this will be very important. It's, public health is an exciting place to work, but we compete with the private sector for compensation. And so getting the skills in public health is another area that it's a growing area, and it's an exciting area to work in. And so we hope that we will get the skills that we need to address big data in public health.
Well, I'm going to leave you with 1 minute to say, what, now that you've been through this pandemic, known the data problems, what message of hope can you give academia, all the partners who want to work with public health? What should we be looking forward to?
I think the attention that this pandemic has given to the impact of health disparities on the entire populations is something that we could be looking forward to, that we could be looking positively at how we were sort of caught by surprise by this, and we should not have been. And we need this to be a lesson learned in how we must continue to be prepared in the future, and how we must continue to look at the social determinants of health to put us all in a better position. And I'll just say with ending, I realize I cut off my final slide from the slide presentation with the resources in my talk, and I can provide those separately. So I think that those resources will help people look at how we can use big data to influence population health in addition to individual health factors. So thank you so much for inviting me to participate.
Thank you, Dr. Bell.